So I think probably more people will be filtering in from breakfast, but we're going to go ahead and get started so we can maybe keep to our schedule this morning. One announcement, or actually a couple announcements before we get going. Please, please, please fill out your evaluation forms that are in your portfolios and drop them off at the registration table out here. Those are really important to us. They help us plan the next event and figure out what kind of sessions we want to have and all those good things. So please do complete those. Second thing is the Gayman's Picnic is on September 27th this year. It's a Saturday, starts at 1:30 at Tina and Lowell's house. And if you want more information or you have questions for them, you can email them at lgayman, so GEHMAN, at espite.com. And that's always a wonderful event. So if you're able at all to go, you know, try to make it for that. And I think those are our two for this morning. I'll probably have more announcements later. But right now, I want to introduce Adriana Glenn, wife of our trustee board member, Bill, who put our program together this year. And I am leaving it to Adriana to tell you a little bit about herself, and then she is going to tell us about the research that she's been doing.
Good morning. Can everybody hear me? All right, great. So first I want to say it's an honor and a privilege to be able to speak with you all today. I am super excited to talk about my research. So I'm going to give you a little bit of background so you can kind of understand how it evolved. Bill and I are the parents of Avery Glenn, who, if you attended Dr. Bergerson's talk yesterday, we're that family. Avery was diagnosed with Alagille while I was working on my PhD at George Mason. And it changed the trajectory of what I wanted to study. I always wanted to study underserved populations because I am a nurse practitioner, family practice, and that is what I was used to working with. So low-income populations, public health kind of stuff. And little did I know that rare disease is very much an underserved population, not one we typically think of. And so it was from that experience of being a mother of a child with Alagille, a rare disease, and the encounters that I had in the healthcare system in terms of, your kid has this, boom. Good luck with that. No help. And I, being in the medical profession, in the nursing profession, had resources and knowledge that many parents don't possess. So I always would think when I'd be at an appointment, like, what if I didn't know this? Or what if I didn't know that? Or what if I didn't know where to go for information? And I became very interested in trying to understand how people get information on this disease. If you're like my husband and I, our daughter, she didn't present with Alagille typically. She was almost 2 when she was diagnosed. She presented with the jaundice, but the heart piece wasn't picked up till later. So her journey was a little bit different than many other people in this room. But that being said, when we went on to search, just like you all, the stuff that came up was scary, and we didn't know what to make of it, and Alagille came on our radar in our search, but other things weren't falling into place. And then when we got the diagnosis, and we're having to see all these specialists and therapists, and you always knew you were in trouble when someone said, Ala, what? How do you spell that? I've never heard of that. And then you have to educate those people on this disease so your kid can get the best care possible. So that's my story. That's our story. I want to talk about my research. It is not, to give you a kind of a context of how I studied the problem. Most research that you've heard about in this room from medical professionals is looking at numbers, using what we call tools and instruments to be able to understand differences between what we would call variables. And the kind of research that I do is looking at what we would call textual data to try to understand and interpret meanings of things. So looking at what people say and trying to give meaning and looking for commonalities and things like that. So my research is a little bit different, but it's going to help you to understand how I came up with what I came up with the help of 16 wonderful moms from across the United States of children with Alagille syndrome. All right. So, and at any point, if you want to ask me any questions, feel free to butt in. Okay, so to give you some background information, just in general on internet usage, you can see that most adults use the internet, and most of them are using it to search for health information, and about half of this number is looking for the health information for other people. And women, for some reason, are more likely to search online for health-related information, more so than men. General search engines are generally used, so those are things like Google, Yahoo, Bing. So that's what generally is used by people in general who are using the internet to look for health information. And parents often are using of any child with a chronic illness, so rare or not, are using the internet to try to find support and information. And the internet and online communication has really helped finding that support a lot easier. I've talked to families, the Alagille families from early on, and how it's evolved, and the desperation when you feel like you are the only one in it. You don't feel like anybody understands, and you have people trying to tell you things like, oh, if your kid itches, try that cream, it works. Try this vitamin, it works. And you get frustrated, or you're out just minding your own business and somebody makes some comment about your child or you. There has been a huge increase in the number of adults that are using social media. Since 2005, we have about 65% of the adults now use social media. And I know when Bill and I started our journey with Alagille, first thing we did was go to the Alliance, and the message board was just starting to go on its way out. And it was interesting as a researcher to see that transition, people moving from the message board to Facebook, and there's a lot of different reasons for that. Some of it had to do with most of it had to do with access, and in fact, there's an app for that. Let's see. So lots of different formats are used. So when I'm talking about online communication, I'm talking about email, we all know. Some listservs, we're being streamed, you got Yahoo, you have social media, Skyping, Google Chat, lots of different formats. There are still discussion boards and things like that. So parents use online health communication to help supplement what they might know or what kind of information they've gotten from the physician, to develop knowledge if they are dealing with somebody who doesn't know anything about it, and just try to learn more so they can advocate for their child. And of course, to develop the social networks, which is what I'm really interested in. It is noteworthy that parents of children who have rare disease use the internet differently. So what do I mean by that? Well, the research shows that parents who have children and have things like diabetes or even pediatric cancers, and I'm not saying pediatric cancer is super common, but it's more common when you look in terms of numbers. Those parents are going to rely on the healthcare professionals for information. They're not going to run right to the internet. The internet's bad and scary, and they don't know how to interpret the information. So that is not their first line. Their first line is their provider, who generally has all the knowledge and wisdom that one is seeking. As they become more comfortable or they need kind of practical advice, then they might shift to using the internet. Parents of children with rare disease immediately go to the internet. And they do this to gain access to research databases, to get support, learn about the genetic disorder, and get information about insurance and things like that. And parents of children with rare disease will use the internet despite the fact that it might create anxiety and stress. So they're going to, you know, we are a rare breed. We are going to just move ahead, and even though that information is scary, we might not understand, we're still going to consult the internet first and then go to the healthcare provider. So basically, the online support group piece, very beneficial for parents. For reasons that we don't know yet, and I'm hoping to do more research, mothers use them more than dads. And it really does help reduce the feeling of being isolated, because we are coming from all over the world, all over the United States, and I would want to, maybe I should ask a little survey. So before you connected with the symposium, how many people knew another Alagille family in their town or state? Raise their hand. Good. How many people ever talked to another Alagille parent on the phone before the symposium? Okay, good. Before the symposium. How many people have been online, whether they visited the Alliance, Facebook, Alliance's Facebook page? How many people have been online? So there you see where most of us are going to connect with others. So, and people that do participate in online communication report high levels of satisfaction in terms of getting useful ideas, finding trust in people that truly understand what the experience that you're going through, and feel more empowered and more altruistic in their endeavors with trying to deal with this awful disease. So from all of that, I was very interested in looking at mothers for my study, for my dissertation. And I picked mothers because they're an easy access population, not because I don't like fathers. They were easy. I wanted to get the PhD done, and the best way to do that is to be able to access your population. So, but that being said, I am definitely open to moving on to fathers. So my study, I interviewed 16 mothers between the ages of 31 to 53 years. And they were all from across the United States, and one came from another country. The kids that had Alagille syndrome ranged in age from 6 months to 17 years. And most of them had peripheral pulmonary stenosis, like we heard in the talks yesterday. 5 of them had additional medical diagnoses not generally associated with Alagille. So what do I mean? Something like ADHD or vitiligo, things like that. We don't expect to find that with Alagille. And 5 children were liver transplant recipients. So I felt like I had a good sample of mothers to talk to. So one of the things I was looking at was, I know when Avery was diagnosed, I felt after, you go through this loss. So you're shocked, you're in disbelief, you're in denial, you don't know what, your world is turned upside down, and you're trying to make sense of things. And after that kind of, I don't want to say, it started to subside a little bit as we started getting connected. We went to the Gayman's picnic, we met other families that really helped us, we were online. And I do have to say that as good as the internet is, there's nothing like face-to-face human contact, which came up in my research. But in any event, I felt this kind of sadness, kind of like this loss for things that possibly were never going to be before the catastrophic thing happened. So things like, she was scratching all the time, and I just felt so hopeless and powerless to be able to really help her. And the fact that she might not be able to play certain sports or things like that. Things that, when your child comes into this world, you have a vision for your child. And when there's this mismatch in how what you want, because nobody wants their child to hurt. Nobody wants their kid to be poked and prodded every couple of months. That's not what you envision for your child. So for me, I just felt this sadness, which in the literature is called chronic sorrow. And I'm not going to bore you with all the theoretical basis of that, but I wanted to know, did other mothers feel like me, or did they feel something different? And how were they using the internet maybe to kind of manage all these feelings that are stirred up inside? So from my study, about half the mothers experienced what is termed chronic sorrow, and then half of the mothers experienced what I termed unpleasant feelings. So that would be things like anger or anxiety, feeling overwhelmed. So feelings that weren't necessarily like a mental health diagnosis, but things where it just really didn't fall in with having this pervasive sadness. And fright was another one. So it appeared that the mothers who experienced chronic sorrow had strong and consistent support from 3 groups: family or friends, online support, and healthcare providers. So if one of those 3 groups, if it was impaired in some kind of way, the mothers experienced more unpleasant feelings as opposed to being able to move to chronic sorrow, which I'm going to talk about as a normal and natural feeling. So in interviewing all the moms, I had to transcribe all the information. So I had to type it up and kind of look at what kind of commonalities was coming out of the information that the mothers were giving me. So there's what's called an overarching theme. Online communication is essential to the rare disease community. So that is what I find. It's essential because we are so spread out and people don't understand. So it's really important to get connected. And that it was essential in managing their chronic sorrow or unpleasant feelings, and that the mother's experiences that were, like I said, if some piece was missing, particularly the online piece, they were they were more likely to feel alone in it, not be able to feel chronic sorrow. The online community offered the mothers new ways of building relationships and connections in addition to helping them cope with the illness of their child's illness. And they were able to share the joys about meeting others and having that personal connection. So the moms used the online information for multiple purposes, and like I mentioned, everybody in my group started out by using a general search engine. That's the quickest, fastest, easiest way to get information. And Google was pretty popular. And by using those things, they were able to, like I said, create the sub-themes: connectedness, online triggers, empowerment, and seasons of online communication help contribute to this overarching theme. So I'm going to kind of go a little bit into more, and I have some quotes that I like from some of the mothers that I spoke with. So this connectedness theme. So mothers viewed connectedness to the online community. It was critical. It was critical that mothers connect with other mothers. Like I said earlier, isolation is predominant in the rare disease community. So, for example, one mom said, it's like a lifeline for a lot of us. The internet enabled mothers to communicate and seek information and support and feel connected with other mothers. Mothers said things like, the community is incredibly important to know that other people are going through similar things. Another mother said, it's such a rare disease that there is nobody around me, at least that's ever heard of it. And another mother said, people are always saying things like, what the heck is that? The personal connection with other parents. This is another mother's quote. The personal connection with other parents and the personal experiences is what gets you through. And then it was just key in me feeling connected and not being alone in it. So you can hear how these moms really connect with the internet. So the mothers in my sample, all of them, I believe, use social media, specifically Facebook. Of course, they use the Alliance website and Google. So that's where they were getting their information. So I talked about earlier how rare disease parents use the internet differently, and so online triggers are things that can cause people to feel unpleasant things and sorrow. And common triggers included too much information, especially early deaths, and this medical piece that I'll talk a little bit more about. So mothers that were seeking information and heavily involved in social media involved negative triggers. So if you've been on Facebook, and sometimes you'll see some sniping going on between parents. Sometimes you see, you see children that have passed away. So sometimes mothers would go online and they'd see these things, and it would stir up feelings of the how fragile life is, and certainly when you have life with a child that has a rare chronic disease. All the mothers experienced the trigger when they learned of someone that died of complications from Alagille. Mostly they learned of this either on YouTube or Facebook posts. And some mothers even questioned why they were looking at this information. It really was, and some mothers had to distance themselves from it. And this was interesting. Most mothers in my sample, actually all the mothers in my sample, avoided reading blogs related to Alagille syndrome because they perceive the blogs as being kind of dire. Like when people are blogging, that is a way that they're using to be able to release maybe some pain. And so they weren't necessarily positive. I mean, I didn't talk with a mom that said, hey, I read a Alagille blog that was this, really awesome that I want to share. So this particular sample of mothers did not engage in using blogs, reading blogs, I should say. Actually one mother even said, I try not to view blogs that much because sometimes they sound so dire, and I kind of don't want to put myself in that kind of mindset like, oh, this is a possibility. Alagille affects every child differently. So one person's story is not necessarily going to be your kid's story. And sometimes people read blogs and they're kind of putting themselves in that situation. Well, nobody wants to put themselves in a bad situation, and we all know that the kids are affected so differently. And another interesting thing about the Facebook, so several mothers in my sample said that Facebook friends cause information overload. There were challenges with having too many friends, not really knowing the people, and having to be privy to their life. So if your moral code encompasses one way, and your Facebook friend who has a kid that has Alagille's moral compass is another way, it's kind of hard when you see stuff and you feel like you need to be friends with that person because we are a small community and you want to give that support, but it's disturbing. So that came out. So Facebook is wonderful, but there are some downsides to Facebook. There's a great quote from a mom that said, I know them because I'm friends with them on Facebook. They post tons of stuff that is of no pertinence to me. And so then that gets kind of like almost overload for me. But I don't want to defriend them because I know them. They have a child with Alagille. And somewhere you can support each other too. It's like I know too many people. I know them, but I don't really know them. And then the final common trigger that was related to online searches was that parents that were looking for information on a specific procedure or something like that, they would read things and it would just spook them. Like some of the older studies that you can pull up have very dire survival rates. And it's just trying to make sense of all that. And one parent said, I did read this one article and I remember reading about, or one mother, that the survival rate age, and that really kind of scared me. So there's lots of things that, even though the internet is a powerful and very useful tool, you just need to be aware that when you're online, there's things that kind of can stir up things and you should be prepared for that. Empowerment, the mothers recognized the value of the information that they were getting from being online. And this resulted in them becoming more empowered, and it gave them a sense of relief and more control. And also the mothers developed a high level of literacy, which is absolutely necessary to be able to communicate with your many healthcare providers and therapists. And they talked about how healthcare providers often didn't view them as a partner. So, so we like to think that we are working with our clients, as we call them in community public health, or patients, and sometimes that's not the case. The mothers quotes like, "You going online, it was important. Online sources, it's important for making yourself literate. It's a must if you're going to advocate for your child." And things like, "I wanted information." And several mothers commented on, "It's really hard to tell who's really the go-to people and where's the best place to engage." And oftentimes the healthcare provider was not the person referring people to get the information, unfortunately. And sometimes the information they were providing wasn't necessarily accurate. One mother said, "We had a hard time getting information from doctors." Some providers, we are consumers of healthcare, so we should be thinking like consumers. But back in the day, the medical care was very paternalistic in the approach and how we dealt with people. And so some providers still function in that role, and some providers withhold information. So mothers didn't necessarily find that too helpful when healthcare providers did not want to give them all the information that they needed to make the best decisions about healthcare for their child. Then the mothers also experienced frustration because of the lack of the professionals' assistance. Then the health literacy, like I said, mothers had to develop a high level of health literacy to be able to engage. And one mom told me, "I remember reading the medical articles and then having to look up every other word because I didn't know what they were." And as the mothers acquired more knowledge and confidence in managing the disease, like I said, they weren't necessarily met on board with the healthcare provider wanting to work as a partner in the best management of the care of the child. Seasons of online communication. I love this. This actually came from a mother, used this term to describe the kind of ebb and flow of the Alagille experience. So seasons, the mom talked about how information-seeking behaviors changed over time based upon the child's illness, the child's development and illness trajectory. So like those early years when everything's kind of crazy and you don't even know your kid's itching and you're trying to get everything under control and learn about the disease, you are hungry for information and you're going everywhere and trying to connect with everybody. And then it seems there gets to be a point where for many of the children things kind of like stabilize, and so then the parents weren't necessarily using the internet for information the same way, or they were using the internet to be more of like a support and empower others that were new on the struggle. So that's what she meant by seasons. So seasons when you're having a bad season, so your kid has to go for a procedure, or you as an adult has to go for a procedure and you're online trying to get more information, you're using it more, even if you had had a stable period for a long time. And then when you're having a good season and things are kind of stable and your meds are working for you fairly well, then you weren't online looking for the information the same way. You might be online to help others, or you're enjoying being online for some other reason. So I loved that term. So summary of the findings: online communication, it has a profound impact on how mothers manage their feelings. It provides knowledge. It helps you to meet other people. It's critical to managing the feelings and increasing the knowledge about Alagille. The general search engines generally serve the need that better than site-specific needs in the beginning. The ability to find the information, assess its relevance and trustworthiness improved as the mother became more proficient with managing the syndrome. And online communication sometimes triggered chronic sorrow and unpleasant feelings. Mothers reported information overload, but they also developed empowerment. Expertise is not always valued by the healthcare provider, and over time, online usage patterns change based upon what was occurring with their child. So what does all this mean for you? You sat here and listened to me. Well, I want to point out chronic sorrow and sadness is a normal feeling and response. So when you are feeling sad, it's an ongoing living loss that you're dealing with, and that's normal. Not to be confused with things like depression. Depression there's different forms of depression, so this is a little bit different. And I'm not professing to be a mental health care expert, but depression, when it's interfering with your ability to carry out your normal activities of daily life, and there are different levels of depression, it's different. Also, chronic sorrow is always precipitated by an event. So like the day I found out my kid had Alagille syndrome, I just felt this, as opposed to depression can be a culmination of events. Your kid is sick, you lost your job, all these things. You can't really pinpoint a time where you started having these kind of feelings. Unlike other feelings like fear or guilt or anger can vary over time, but any unpleasant feeling could be a result of not having all of those pieces in place, the medical piece, the family, friend support, and the medical support. But I definitely have to say I have to do more research on that, but that's my guess. Engaging in online communication is really critically important. Starting the conversation with your healthcare provider, you should start the conversation with your healthcare provider regarding online communication. And supplement your online communication with general organization that helps you to communicate effectively with your healthcare providers. So, what did I kind of got off track here. So yes, the one thing I did want to say about the starting the conversation with your healthcare providers, please, you should talk with the healthcare providers in terms of what sites you're visiting, and they might be able to guide you to some sites that might be a little bit more helpful. Because Google and Bing and Yahoo are wonderful, but there are medical databases and genetic databases that might give you a little bit more information for certain things. So I can tell you as a healthcare provider, it means that we have a lot of work to do in terms of supporting Alagille families and all families facing rare disease, and trying to help support the emotional and mental health of families, which we know dollars are limited. We heard yesterday how it's really hard to get funding for rare disease, and then one of the things that drove my research is, we still have to protect the emotional health of parents, because there's a saying that, if mama ain't happy, nobody's happy. Well, if mama not functioning, nobody's functioning, and the same goes for dad. So if you are not in a good place and you don't have the right support, it can be really hard for you to manage a very complex disease. So I had the opportunity to get advice from the mothers in terms of what should people be doing, and so that is talking with providers and being organized. And actually, let me see, I did think I wrote down a couple things so I wouldn't forget that they told me. Yes, in terms of supplementing your online communication, the suggestions that the moms gave me: have a prepared list of questions for each clinic visit and make sure you get your answers. And what I mean by that is, look, folks, there are bad people in every profession. So if you have a bad experience with a provider and you have the ability to change, please do so. Speaking from experience, our first GI doctor was horrid. Horrid. Did that shake my faith in the healthcare system? No. Because I knew that one person didn't speak for everybody. And so for us, we had the ability and the means to go someplace else. So please, it's not a one-size-fits-all. And what I really like about the fact that we've had a lot of different people talking to us is that you don't have to have an expert in Alagille for some things, okay? You can have that connection, and if you have a good connection and that trust, believe me, when things are out of that person's purview, they will refer you on, or they should refer you on. But look for someone who's, our pediatrician was not, he had Alagille. Bill, was Avery the first? Yeah. He, in 30 years, he had never seen an Alagille child. We love our pediatrician. He took the time to try to understand and get us to the right places. We wouldn't change. We would not have changed. We have not changed, and I recommend him highly. So for people that are more in outlying areas that don't feel like, they can't get to the big medical centers and they don't really feel like they're getting the best care, just establish a trusting relationship with your provider and know that that person has your back and that they will consult people when need be. So that's really important. Other things that maintain a notebook or an e-document. I think the person that comes on after me is going to talk about that. So that's really important. And document, keep track of the people you see when your kid's in the hospital. If you're in a teaching hospital, you got like a bazillion people coming in, treating your kid like they're a zoo animal almost sometimes. It's very upsetting. And, you just want to just get out, but you try to remember that they're there, they're trying to learn and, become expert so they can help us all. And you do have some controls, but you need to kind of work that out with your nurse and the healthcare provider in terms of, the numbers of people and the kinds of people that come in the room when you're in a teaching hospital. But it is important to write down everybody that you see. You can tell, everybody's got their own little system. GI people have their system, the cardiac people have their system, the kidney people have their system, and they don't always necessarily talk. So if you keep track of all the people that you're talking with, did you check with that person? It's a lot of onus on you. Doesn't seem like it's fair. You didn't sign up for it, but you're the best person to take care of that situation. So in closing, I'd like to say thank you for allowing me to share the findings of my dissertation. And so I feel like Avery's legacy is my experience of being a mother of a child who lived with and had this awful disease. And our experience allowed me to develop a study about using online communication to manage feelings. So I hope that my talk creates a greater awareness of the importance of the online communication in psychosocial health in the Alagille community and any rare disease community. And I'm done. Any questions? Yes.
You said there was a bit of a difference between people who just got information online versus people who actually came to an event like this.
Mm-hmm.
What were some of the big differences?
Yes.
I pretty much said my question, but I'll say it again. You said there was a difference between people who saw and met people online and just the online experience versus people who've actually attended an in-person event like this one or one of our Alagille family days or something. What exactly are those differences that you noticed?
The mothers just talked about the need to actually connect. And one of the things like I saw last night with the kids dancing and playing with one another, Alagille kids and kids that didn't have Alagille, that kind of stuff you can't get from the online. So actually being able to have a face-to-face, and hey folks, we know there's some people that are paraders. I've seen them on some of the Facebook sites. They act like they got a kid that's got issues, and I don't know what satisfaction they're getting. Not necessarily from the Alliance Facebook page, but I have seen other Facebook pages where people are posers, that they have a kid that has problems, and it's not the case. So that face-to-face real connection where you know that you're really dealing with a person that is genuine, authentic, seemed to be very important for all the moms that I spoke with. So things like this are, the picnics, the Alagille days, all of that stuff, it's really important to try to get connected with somebody in your location if you can. Any other questions? All right. Very good. Thank you.
All right, so Courtney is going to make her way up here and going to do a little microphone transition. And
Yeah.
So I'd like to introduce Courtney Larned. Okay. Wasn't sure how to pronounce that. And she is with CareSync. And as I did with Adriana, I don't have my bio. So if you could give a little introduction, that would be great. And she's going to talk about really important managing medical records.
Really, really exciting topic, I know, but it is actually quite critical. So I'm going to switch up my presentation just a little bit in the order, only because I want to piggyback off of what Adriana just said. CareSync is a company that exists because of rare disease. Our chief operating officer, there's actually a team of us that worked together since about 2004. We built an electronic medical record. We sold it to a publicly traded company, and then we kind of went off and did our thing. A lot of people went on to the other companies. Some of us started building a platform to do other things. And in June of 2010, our former head of development and now current chief operating officer, her daughter was diagnosed with juvenile dermatomyositis, a rare autoimmune disease. There's about 5,000 children that have it. And she was a nurse, is a nurse, and she was also the head of IT healthcare development. And she could not manage all of the information, all of the different providers, the specialists, super specialists all over the country, NIH, all these things. She was not able to manage it. And it was kind of like an aha moment, like, what the heck? If I can't manage all of this with my education and my clinical experience, then who can? So that's kind of the birth of CareSync, and that platform that others of us were working on turned into kind of the base for the CareSync platform. So let's get through some of the boring HIPAA and fun stuff about records and get through the right stuff, and then I can share a little bit more about what we're doing. So, like, you need access to your important medical records, and when you have a rare disease, it's even more important because each little piece of data, it becomes pertinent to you, becomes pertinent to your providers, and let's be frank, as well-intentioned as providers are, communicating isn't always the thing that happens. So multiple specialists, complicated symptoms, super specialists at NIH and other centers of excellence take a bunch of medications, and then your providers don't always communicate in time. Because of HIPAA, you have a right to your medical records. You can view the originals at the office typically, or you can request copies of the records. You're allowed to request records on behalf of yourself, your children, although there are some exceptions, and anybody else who has made you their designated rep. That's done by submitting in writing, I would like to give Courtney Larned permission to get so-and-so's records. The exceptions for children is that the child is consented to medical care and parental consent is not required in your state. They do not have to give you access to those records. If the child gets medical care at the direction of a court, that would be a unique situation where the parents would not have right to the information. And if the parent does agree that the minor and the medical provider can have a confidential relationship. So those are just things to keep in mind in terms of, especially as children get a little bit older and have confidential conversations with their doctors. Some records may be withheld. Typically, this has to do with mental health. Psychotherapy notes do not have to be shared. If a doctor is compiling information for a lawsuit, they do not have to share it under the law. And any medical information that the provider believes could reasonably endanger your life, your physical safety, or the physical safety of someone else. How much will it cost? Unfortunately, I don't have a good answer for you on that. It's different in every single state. Also, the term reasonable, and it always has kind of air quotes around it, is what is required, but it's typically 50 cents to $1 a page. I believe that's ridiculous, but it is to cover administrative costs that they have. And then some offices don't charge. A lot of times the specialists and super specialists will give you that information to take back to a primary care doctor. Under HIPAA, and this started as of January 1st, you're actually required to get access to your records within 30 days. It used to be longer. Cool thing about this is some states are a little more forward-thinking on this, and they have even stricter requirements. California, for example, you have 15 days to get copies of your records, and they have to give you access to view them within 5 days. If you want to go and get your medical records, there's a lot of steps you need to know. You kind of need to know the process for the specific provider, so I recommend that you call them and you ask them what they want to do. They will also want a request in writing, so you'll want to include information like your name, email address, the medical records number if you know it. Some of them will require a social security number. Really what they're trying to do is to get as much information to make sure they are giving you the correct information. Records do not have to be released to you under the HIPAA law prior to payment, however. If they require payment, you have to pay it. They can say you have to pay it before they'll give it to you. Let's see, complete the form. So yeah, so then you make the request in writing, you include all the info that they require. Most of them have a HIPAA authorization release form that they would ask for you to complete, and that would be who you're going to release the information to. So if you're having it sent to you, you would put you. If you're having it sent to a specialist or a different doctor. And then you specify if you want copies or to have an in-person viewing of the original medical records. That typically would be if you were worried about errors or if you wanted to see the original specifically, if you were getting into legal stuff more than anything. So switch pages here. They also recommend that you be as specific as you want. So if you've only seen this doctor for 2 years, don't request all records for the last 10 years or anything like that. So the more, they kind of triage the requests as they come in. So if you tell them why you're requesting the records, I have an appointment at NIH next week and I need this information, they will give it to you faster than if you're like, I want everything you've ever done on me, just for the heck of it kind of thing. So our team, that's been our experience, is they really do triage how it happens, and then they, the speed of which you get it, it goes from there. What if my request is denied or my records are not complete? Typically, if there's an error in your medical record, it is an honest mistake, a simple omission, or in the EMR days, a lot of copy-paste happens. As we collected records for some of our clients, actually my best friend asked for CareSync for her birthday. We're getting older and I guess starting to care about this stuff an awful lot. But the first record she got in said she'd had a mammogram at 28 years old and had family history of breast cancer, none of which was accurate. So it was clearly a copy-paste error that ended up in her chart. And funnily enough, my sister apparently had a mammogram when she was 17, according to her medical records, which would be another error. So it is really important to see what's in there. But typically an error like that is not on purpose and it's easy to correct. You can make a written request to your provider and ask that they change the record. Technically, they don't have to change the actual record because it is a legal document, but they do have to put an amendment in the chart. If you are having troubles with that, there are really two channels you can go to put in a request or complaint. So you could file with the Office of Civil Rights under Health and Human Services. And I put the information there, but I actually have a link that you guys can go to with the whole thing to download if you're interested in more in-depth information on anything that we're talking about today. The second option is to go to the state medical board. I did a little bit more research on this because I don't know much about it, and everything I found said that's kind of not the way you would go about it, as they take a long time. The average time to address a complaint in most states in one study was 2.6 years. So if you're trying to get something done, I did find it from a healthcare law website, so hopefully it is legit information, but if you're trying to accomplish something, that's a roadblock. So, so my advice would be to go to Health and Human Services. I actually know quite a few people there, and they will, most of them will bend over backwards to make right on it. Yes, 2.6 years, that's what I have. So now it's like, I've got them, now what? So however you do go and get your records, you need to create a plan for organizing and storing them. Are you going to store them in binders, banker's boxes, in the trunk of your car? Are you going to get a personal health record or another technology solution to store them? And if I can drill anything home today, discover what's in them. So get your data, get it in a format that you understand it, but discover what's in it. Discover those errors. My colleague that I was telling about the rare autoimmune disease took years to get a diagnosis, years, and in 2005, she'd had her tonsils out, and they actually had found traces of autoimmune that was just never conveyed to Amy. So had she had that information sooner, she might have had a diagnosis much sooner and treatment much sooner. So discover what's in them, review them for errors and omissions. We, as the parents, as the family members, we are the best source of information at the end of the day. We are there every single day. We are there taking care of our family, and we are the best storytellers when it comes to telling the story of health. So remember that. So even if you do feel a little bullied by a provider or that your information is not relevant, it actually is probably the richest source of information for the doctor to put the story together. Report errors, like I just said before. Get them taken care of and get the amendments fixed, and make sure you communicate them to your other doctors. If you have a nephrologist and there's errors in that chart, you really would want all your other providers to have the update on that as well. And then make your plan for sharing with them. Kind of build that partnership. I know you touched on partnerships a bunch, but I really do believe that you can, if you go in engaged and empowered with information, you can establish a really strong relationship with your doctors, and they really will trust the information that you bring as being more valid than you might feel in typical situations. So I told you a little bit about our story, so we can skip over that. But this is what we do. So we go and we have built web and mobile applications for iPhone and Android. And as we were building them, we realized that the reason a lot of the traditional personal health records haven't done so well and have not had huge adoption, and same with the portals actually, is because it's a lot of work and because getting your records is incredibly overwhelming. So we actually hired a whole team. There's a call center in Central Florida, and we go and get your medical records. It's not easy. We actually lose money on a lot of the patients that we get records for. We don't on others, but we get all of your records. We scan the complete ones in, but then we actually go through and we transcribe each past medical visit and build them out in the CareSync software. So all of your past medical visits are basically put in as appointments, but they're just past tense, and the plan and assessment from each of those visits is typed up or copied and pasted, electronically brought in where it could be. So health conditions, medications, allergies, all of that information is put in a structured and codified fields, which if you're not techie, basically means it comes from databases, not from I typed the wrong letters in the spelling of this medication. So you start typing up medication, it will come up in the software and you can choose it. It will recommend which doses are typically the doses that you do. So they go and they put all that information in, and what that actually ends up doing, the what you get from it, is your health timeline. And the health timeline is actually, it's a nerdy way of actually being really cool. But it is a timeline of your past medical history, and you're able to filter it by health condition. You're able to filter it by date range. So if you see one doctor 4 times a year, you could give everything for just the last 3 months. But you're able to say, instead of showing up with your big binders or your banker boxes in a cart, you are able to show a 3-page summary of your current status as well as the relevant past medical status. So here's a picture of the health timeline. So you can kind of see it goes down. The provider notes, that's the information that our team would go and put right into the document. You have your whole family on the left. So right now we know we're in Lucy Carter's account, but then you can just see there's all the medications that are linked to that, any documents that might be linked to the appointment. And there's also a place for you to put your own notes. You referenced having your list of questions and making sure you get them answered. We have tasks built in there, and not everyone uses the tasks the same way, but I actually use the tasks to create an agenda for my doctor's appointments. And I check them off as we go, and I don't leave the room until, nobody leaves the room until my questions are answered. But I leave feeling confident, and I leave documenting some of these things, because a lot of the times, I mean, the statistics are 50% of the people forgot what the doctor said by the time they get to their car. Even more so if you get a shocking diagnosis. You go about it like, wah, wah, wah. You don't hear anything else other than that. So we have built tools. We've leveraged the technology that's in our phones already. You can leverage the voice recorder in your phone and actually record the doctor's care plans. So then it's part of the record. And family on the other side of the country, we talk about social networks. We think the family is the original social network. So by having your family involved, the family and care team, you know, dad can hear the records if he wasn't able to be at the appointment, grandma can hear them, hear what the doctor said, and everyone has access to that. And I will tell you that I was actually shocked. When we did this, I was like, doctors aren't gonna go for that. They've actually loved it. They've actually been really, really embracing of recording the instructions and having the patients do what they said. So the other thing our team does, we'll actually schedule appointments for you. We're kind of moving a little more toward a concierge-esque business, where we schedule appointments and put in tasks and care coordination type of things. So if you're managing complicated conditions and things like that, it could help just carry some of that caregiver burden. Like I said, we have some pretty cool technology. We have really, really easy to use apps. Web, iOS, and Android. The web is great for putting in some data and stuff like that. But one thing I actually did not emphasize, which I probably should have really emphasized, is that it's super, super, super easy to start. So all you have to do is put in your doctors, and we have a database of almost all the doctors in the United States are already in there. And then you hit a button that says request records. and you digitally sign that HIPAA authorization release form. You can use your mouse, or if you're on your phone, you use your finger, and send it, and then that's it. Our team does the rest of the work, and you get notifications as records come in and your account's being populated. So Care Manager is kind of the tool with all the appointment tools and the tasks and all of that, so people can collaboratively participate. I actually recently was doing a demo, and I happened to be in my live account instead of a demo account. So I typed in a task, like pick up prescription at CVS for Benjamin, and then like an hour later, I get a response on the comment on the task that said, I went to CVS, but they said they didn't have anything for him. Was he waiting for something? So it really is social. My husband had hopped on there and gone to the drugstore to go do it. So it is actionable things, and people really do get involved. So silliness aside, I felt really bad that I wasted like 45 minutes of his day, but it does work. People really do want to do that. We've had a lot of people go through, if we're going through a series of treatments, one colleague went through radiation, and she had 20-something of them, and she put each of them in as tasks, and each time she went, she checked one off, and her family cheered her on and gave her social support. So really, you can really socially encourage. You can bribe. We have medication reminders and adherence now. So my son has to take medicine each morning, and I bribe with Legos. So if he gets 31 days in a row of tracking his medications, then he'll get some Lego prize at the end of it. So there's some gaming you could do, and social psychology things that you can do to help with the adherence and all of that. One of the things that's coming out in August that I'm really excited about, but I'm also a super data nerd, is tracking devices. So I have my Fitbit, my Jawbone, I am actually wearing both of them right now. But any of those scales, things if you're tracking weight, blood pressure, any of those types of things, we're integrating with those wearables. So that takes that kind of behavioral data, overlays it with the clinical data, and then the family data on top of it. So it's really this rich source of information that then you're then able to share with doctors. Like I said, we have some concierge services. We do appointment booking. We are really proud of the statistic that 98% of the appointments we've booked have been attended. So I don't know if it's just to put it on my calendar and I show up kind of thing, because that's how I am, but people are getting to their appointments. We've had a lot of people who go to super specialists, and when they need to go, they need to come with the concise packet of information. And NIH actually has a huge cancellation rate because people aren't able to get prepared before that. So we're working with them and a lot of their patients to get them prepped for their residents and the care coordination around that. Here's some of our just great successes that we've had so far. 64% of our Plus members have avoided duplicate tests. So far, the longest record we've had is 4,089 pages. That one was ugly. Oldest record is from 1966, and the most providers any of our patients have, and this is probably about a month old, so hopefully it's still current, was 49. So the members who use the services are 9 times more engaged in their health. There's 9 times more activity in their account, and 1 in 3 found significant medical errors in their charts. So that would be, I have a mammogram, or there was autoimmune traces in my tonsillectomy, things like that. So, and then with CareSync Plus's help, 84% remembered their post-visit tasks. Our doctors, we didn't know at first if we were going to tick the doctors off or not, but they've been thrilled. I actually left my last doctor's appointment with a high five, so we'll count that as a win. And then CareSync has simplified a very chaotic life. We recently had a post on our Facebook page, and it was a picture of 2 banker boxes that were carried in the trunk next to a picture of her iPad. So it's a much more portable way to carry your information around. So for the sake of full disclosure, there are other apps and services available. Zwina Health, I think, is really our biggest competitor in this space. They do not have their own technology. They use Microsoft Healthful technology, has mobile web browser for web access for Android, and I do believe they have an actual iPhone application. I think they cost more than we do, but they seem to be a really up-and-coming by that. MediFile's been around a little bit longer. They are also a services business. CareZone does not have services, but I think they're a fantastic PHR. I would say we're very comparable in terms of that sense of what we've had. They had the medication adherence, the family collaboration, and things like that. And then Blue Button is a government initiative that we all have access to information, and they're working so hard to it. There'll be a national campaign later this summer, early as fall. So I think people in general, not just patients, are going to really have the importance of having access to information. So Blue Button, if you go to the Blue Button site, it's very early right now. I just went on it a couple days ago before I put this together. And I live in Baltimore, and I typed in Maryland, and right now MedStar and Hopkins were the only two on there. University of Maryland isn't feeding that information into it yet, and Hopkins still isn't feeding that much. So it'll be very fascinating to watch how this rolls out over the next few months and years, but there are a ton of apps, and I'm happy to provide some of the names if you want to play with those and see getting that information in that way. I should point out that for CareSync, our apps are actually all free to use, download, sign up for, and then we only charge for the services, and pretty affordable, all things considered, but we'll go and get medical history for $99. But like I said, not a marketing pitch, there are actually a lot of apps out there that are doing a really good job with this. And that's pretty much it. Does anyone have any questions about any of the legal stuff or CareSync stuff?
Just have a general question. What is like the email or PDF capabilities built in? So if you wanted to get like a timeline of like the last 3 months and you don't have an email to us, what are the capabilities built into the app?
So the app actually is built on a fax server, which fax, but it is still America's favorite healthcare device, I would say. So what we wanted to do is we wanted to make it very, very simple. So you've now, say we've built out your complete health timeline and you want to send in the last 3 months. All you do is, and I don't have internet, but I'm happy to show you, you filter out what you want, you hit share in the top right, you can either print out a copy or you can hit the fax button and it will fax it off to the provider that you choose. So you can set the system up to automatically send something the night before. So it's sitting on the fax machine. And I actually have a story that has nothing specifically to do with you, but in a general one. But I actually fell running in January. And I broke a bunch of bones in my hand and ended up having to have surgery to rebuild a finger in February. And I have a neuro condition that is well managed. And the anesthesiologist who I met 15 minutes before my procedure kind of wigged out. He was just like, I don't feel comfortable doing this. And I was actually able to share everything he knew. This was at Maryland and not Hopkins, where my neuro is. And I was able to share everything he needed to see. I sorted by health condition and the medications that I take. And I said it will be on this is from the OR. It will be on the fax machine in the nurse's station by the time you get there. And he's just like, by the end, he wanted me to hire him and come work as our chief medical officer. So, I mean, that's pretty powerful. People had taken the days off from work, and he wanted to send me home, and it was not cool. So by being able to share the relevant data right from my iPhone that was almost dead because I'd spent the last 3 hours playing on it, but he had the access to the information that he needed. And they say 80% of diagnoses can be made with stories and not tests. So certainly, you know, as healthcare costs continue to go up, and I firmly agree that we really need to get into a consumer mindset when it comes to shopping for healthcare. You know, if the service isn't great, go somewhere else, that kind of thing. But I really think the portability of this information makes it a lot easier to become a good consumer.
What facilities do you have to take lab results and take them in PDF form or some other, paper form that we might put in there, and produce any kind of graphs or charts or anything that, most of us have kids that go for labs on a very regular basis, and we would like to see trends.
Yes, that is part of the behavioral and tracking information that's coming in. Will be really the visualization around a lot of that data. So right now the data is getting put in there. We kind of build in medical buckets, if that makes sense, but actually the visualization around that is coming in the next build, specific to that kind of things.
Okay, well, thank you, Courtney.
Thank you very much. I'm humbled to be here.
So I think we are at break. Yep. So we're at break till 10:15, and then we are going to have our enormously popular teen panel Q&A. So go grab something, and we'll see you back in a few minutes.
Okay, we're going to go ahead and get started with our keynote address. So our theme this year, we thought long and hard about what the theme of our symposium should be for this sixth symposium. And one of the things that I think every family in this room struggles with is how to navigate a new normal with Alagille syndrome. So that's kind of what our address is going to be about today. And we have Dr. Richard Ruth joining us. And he is an associate professor of clinical psychology and director of clinical training at George Washington University. He's on the faculty and steering committee of the Child and Adolescent Psychotherapy Program at the Washington School of Psychiatry. For more than 30 years, he has devoted much of his professional time to working with children with disabilities and chronic illness. In addition to his teaching and research, he has a clinical practice here in DC. He has personally lived with chronic illness for over 40 years. Not to give it away, right? So please join me in welcoming Dr. Ruth.
Thank you. So, yeah, this thing really works. That's amazing. So you've already learned that you can go to guest services and get to the head of the line at any amusement park. That beats anything. I have to say thank you very much. There's always a little thing to try to get through when I say that I'm a psychologist, and many of the people I'm speaking with think, well, but there's nothing psychologically wrong with my kids, so could they go back to the helpful hints about the amusement park, please? And what I want to say is that while there's a lot of psychologists that don't get it about what you're dealing with, there are also a bunch of us who do. So I'm not making any assumptions that your kids are not the fantastic kids and you're not the fantastic families that I know you to be. Plus, I've had empirical data sitting in on the last session. Washington traffic was kind for a change, reinforcing the theme that you never know what to expect. I want to talk about a few things that my work with kids and families dealing with chronic illnesses leave me thinking about. I want to make clear to you that I'm not an Alagille specialist. I'm a psychologist that works with kids with lots of different kinds of chronic illnesses and disabilities and their families. That thing about it's all the mother's fault, like we buried that a long time ago, but it pops up every now and again. I don't think that, and I know that you don't. I think that while there are things that are particular to Alagille and to other syndromes and that those are important, there are also a lot of things that extend across a lot of different syndromes, and that's my center of gravity, and I'm going to try to download as much useful stuff as I can. First thing I want to start with is that we're usually not just talking about a syndrome or an illness or a disability. And you heard that directly from the mouths of the kids who spoke just before me. There may be one central thing going on, but there's also a lot of other stuff going on. So your liver and your heart and your energy and your feelings and all of this. And it can easily be broken down. I'll share a little bit about my lived experience. So I have diabetes. I've had it for 40 years. Related to that, I have low vision, and I have a mobility disability, and probably a couple other things. And that's part of who I am. And so I'm real careful about where's the ramp, and don't give me things written in small type unless you want me to ignore them, which can be fun sometimes. But there's also a lot of other parts of me. One is that I'm Jewish. So my very first question when I was invited to speak here, which I'm excited to be here with you, was, is it on a Saturday? Because if it was, I would be somewhere else. I'm also Argentine. So my second question was, who's playing today in the World Cup? And you know, you deal with different things in different ways. You do what you have to do. And as your kids explain to all of us, it can be very practical. A Saturday, I can't move around. On the other hand, I have FiOS. So whatever is playing today, I will watch later. And playfulness and a sense of humor are all important. So I'm pretty down to earth, but I know a lot about statistics and research and science and theory and other things. So a little dose of that. In particular, so the next time you're dealing with someone in a white coat, you can use big words too and intimidate them. There are a couple of theories about chronic illness that are, what would be a polite technical term, garbage. But I'll mention them so you'll know how to smile and talk back to the right people. So one is that chronic illness is a gift. And as far as that gift in me, I would like to know what department store I can return it to. There are gifts that you encounter along the journey. Sometimes there are lots of them, and they're wonderful, but it's not a gift. I resonate with the young person who said that they wouldn't change their reality for anyone else's. I'm real happy with my reality. On the other hand, it's not a gift. There's a different name for it. The other notion, which comes from outdated science, is that you get a diagnosis and then you mourn it, and then you're fine and life goes on. That's not true either, because what happens a lot is the next obstacle or the next bit of bullying or the next insult or the next school system that doesn't want to do the right thing is a new insult over and over again. So there's not just one thing to be mourned and gotten over. There are things to be lived with. Some of them are pretty difficult, and while I can be playful, I don't minimize those in any way. There's a phrase that is kind of poetic. It comes from the work of Wolfensberger, who has too many syllables in his last name. He should have shortened it to like Wolf or something like that. Like Ellis Island shortened my grandparents' last name. And while I'm on that, if any of you were wondering, I really am Dr. Ruth, and you can laugh as much as you want. If I knew I was going to be a psychologist, maybe would have changed it back to the long version. But he talks about the underground river of sorrow. And while our lives are not sorrowful, there is that little trickle in the basement, and sometimes it's just helpful to put it into words. We're living lives that we know people that aren't living them, and there are challenges to them. So what do you do with your extended family and the neighbors, and for many of us, the people in our faith communities or co-workers who don't kind of get the lives that we're living? I think the best thing to do is you either tell them, or if you prefer, you don't tell them, and you just go on living your own life. For a period of my career, I worked in a mental health emergency service that very helpfully was housed in the local police department. Because when things kicked up in the middle of the night, no one really wanted to go to a clinic that was all dark and spooky. Actually, some of the kids did like going to the clinic that was dark and spooky, but no one else did. And the police department was always open and had good snacks. And so over those years, I got to know a lot of police officers and firefighters. And they would talk about seeing sides of life that most other people didn't see. And as a psychologist, that was our bridge. We were different, but we had that in common. And I remember once asking this officer I got to be friendly with, I won a lot of money from him at poker, and that built a good friendship. It was penny poker, but it was very satisfying, actually, a bag of pennies to carry home. And I said, well, you know, do you talk about this stuff with other people? The stuff that, you know, we see on our shifts? And he said, well, you pick who you talk to, and sometimes you do, and those are great relationships. And sometimes you just let it go, because people aren't going to understand. I want to talk a lot about health professionals and healthcare, in part because that's what I do. And while I have a white coat in the closet somewhere, I'm not wearing one this morning. And I want this to be an experience where I can talk about my world and you can talk about yours, maybe a little more freely than sometimes happens between folks in health professionals. You have to, well, you don't have to, but you can get a lot of mileage from figuring out the ways in which science, health systems, doctors, nurses, other kinds of professionals can give you some of what you're looking for. I want to talk about what some of those ways are. I'm going to talk about this in a pretty plain-spoken way, but the scientific evidence behind it is really solid. Number one is to find ways to talk so that doctors will listen to you. Come in with a list, because you know how they can intimidate you? The list can help them not to intimidate you. Remember, I once worked with a family of a kid who had fallen and broken his back. And the main kind of doctor they had to deal with was a spine surgeon. Really busy guy, great with his hands in the operating room. He had the bedside manner of a slug. It was awful. So he flies into the room like his white coat was flapping behind him. And he says to the kid, "How you doing today?" This kid had a broken back and chronic pain and a lot of stuff going on, but he was a nice kid. So he answered, "I'm fine, doctor." Doctor flies out of the room, writes in the chart, "Patient is feeling fine, ready to be discharged from care," meaning no more PT prescription, which would have been fatal. So I was speaking about that with my 12-year-old patient and later with his folks, and we were figuring out creative, playful ways of what to do. We were talking about making a list. Well, you can always count on 12-year-olds to have more creative ideas than you do. He got a roll of paper towels and a magic marker and started writing his list on the roll of paper towels. And then the next time he saw the surgeon, he unrolled the roll of paper towels. And when the surgeon said, "How are you today?" he started reading from this roll that was spilling out all over the guy's office. That got him to stop and pay attention. As parents, you can provide the kind of very detailed observations that help doctors and other professionals do their best kind of work. Ask all of your questions and do not let them rush you. Why don't you repeat that after me? Again, do not let them rush you. Louder. That's right. Do not let them rush you. So here's a great story. I was once working with a little girl with chronic illness, and she, like me, walked with a cane. I'm bimodal, can walk a little bit. We both walked with canes. So her doctor was making hospital rounds and would come early in the morning when she wasn't quite awake and barrage her with all these questions and then fly out before she could really ask him what she wanted to know. So she was asking me what to do about that, and I said, you really gotta attract the guy's attention. You can poke him in the shoulder, you can shout, you can wave your hands, and she was nodding real vigorously, which always gives a psychologist the delusion that someone is agreeing with you, right? So the next morning, she was full of our conversation, and the doctor rushes in, and before she could get her questions out, he was about to walk out. So she tripped him with her cane. And he fell and broke his leg, which isn't funny, but actually it sort of kind of is. I'm not the kind of psychologist that gets angry at kids for stuff like that. I mean, I admired her technique and wondered when I might replicate it if I would ever have to. But the really interesting thing came later that day in the cafeteria, actually 2 weeks later, when the poor doctor was out of the hospital and comes in with his leg in a cast and crutches and, all this stuff. And he comes up to me, and for some reason, he wasn't happy to see me. I don't know why, really. And he said, what did you tell your patient to do? I said, I told her to get your attention because she had some questions that she needed you to answer. And he said, well, look what happened. And I looked at him and said, did it work? And we've had a wonderful relationship ever since. See? Fully recovered. Health professionals tend to be very busy. We tend to be very stressed. We have a lot buzzing in our minds. It's useful to know that and to make space for that, to be respectful and to be empathic, especially when it's hard. And it's also real important to get in their face. Why don't you repeat that one back too? Get in their face. Louder, please. Get in their face. I have an eye doctor who is the reason I can still see. Not supposed to be able to see. And he is like one of the 5 world experts in what I have. And I go in, it's been a lot of years now, I go in with my lists. I have about 45 seconds to convey them to him, and he knows that's coming at the end of every appointment. I look him in the eye. I ask my 3 things. I'm concise. And he always answers the questions. That's where you want to be. One day he gave me 2 minutes instead of 45 seconds. I was shocked. I said, "What happened? Are you okay?" He said, "No, it's that you're good." So that's where you want to get to. The other thing is that you want to listen so that your doctor can talk. A doctor is going to want to know what kind of information, what kind of detail do you want to take in? Do you want to get out of there quickly to go to that pizza that, we've just learned that we're expected to provide at most visits? Alternatively, it's some other kind of exciting kid food. You might want all the details. They don't know off the top of their heads. I don't know what you're going to want. And you want to listen to what they're saying in a way that encourages them to talk more. 4 years ago, I was in the hospital unexpectedly. Something really, really bad had happened to me. Details are not important. It wasn't clear how this was going to pan out. There were 6 different kinds of specialists assigned to me. I was really lucky. I was in a great hospital. That was because I told my partner, "Don't take me to the local one. We're driving 20 minutes farther to the one I want to go to." And I gave that look that meant I really mean it. And we got there, and so the 6 specialists came every morning. And a lot was going on. There was a lot to take in. They had a sense of who I was. One morning, one of the specialists lingered after the rounds and said, "I don't usually say this to people, but from the way you've been listening to us, it rounds every morning. I think you would want to know this. We're doing all we can. We're doing and I knew all those words. I knew all the technical terms I wanted to know. And he said, "You're probably not going to make it." And that was exactly what I wanted to know, because they'd all been overly rosy with me, and I knew I was in bad shape. I wanted to know that so I could figure out my own strategies and options. The point was that I had given them the notion that I was going to listen in such a way to draw them out. That often is a useful tactic. There's a notion that my colleague, Dr. Ann Steiner, has developed called the Pain Price Index. So there's a lot of standard healthcare discourse that says, don't do this, and don't do that, and don't do this, and don't do that, and do this, and do this, and do this, and do this. And, there can be a lot of wisdom in that. Like we heard, you got to take your medicine. You don't want to take it. That's very nice. Take it, You got to go to your appointments, else you won't get the pizza. You got to do all these things. No contact sports, no this, no that. But the other reality is that if there's a price for something, and it's something that you really, really want to do, sometimes you decide to pay the price. So we heard from a teenager that really wanted to ride horses. Are there risks to that? So I've been told, because I'm not riding any horses. She can ride my horse. She really wanted to ride a horse. After conversation, after thought, after planning, after safety measures, she has an intuitive sense of the pain price index. In her situation, in her family, with her reality, riding that horse is a great idea. And then there's the notion that I owe to Alcoholics Anonymous, a very wise group of people, which is keep showing up. You gotta be thorough. Sometimes you gotta let the treatments work to find out whether they're gonna work or not. Sometimes you have to try a lot of different things. I like that notion about the silk sheets. And I trust you, I am never going to hear the word cool again. As a child psychologist, I hear that many times per minute without thinking of your kids and those ice water baths. You have to figure out what's going to work. Maybe the one oatmeal won't, but the one in the sock will. Got to keep your follow-ups even if you're not sure why you're going, because that's how relationships develop, and it's when you have a relationship with a healthcare professional that the best outcomes are going to happen. The other thing is that you may be going to doctors who just aren't giving you what you need. And you may have to keep on your journey and find a different center or a different person who's going to solve a piece of the puzzle. Here's a story about that. A number of years ago, I was working for a university that sent me to do some research on a tropical island and paid the bill. I thought that was really great. I got the airplane, the hotel, and the coconuts. I also got a skin disease. And I came back with a pretty miserable skin disease. So all those stories about itching, been there, done that, was paying attention. And I would go from doctor to doctor, trying to figure out what, if anything, could be done about the skin disease. Year and a half, 12 different dermatologists, nothing was happening. So finally, I got a job at a hospital that gave me HMO insurance. And I dutifully said, well, I'm your patient now, so send me to your dermatologist. This was in New York. Their dermatologist worked one afternoon a month. It was a bad HMO. Everyone know that technical term, bad? That was what I got. And it was in a neighborhood of Brooklyn that I didn't ordinarily travel to. I walk into this because I was still searching. Guy looks up at me, says, hello, looks down and starts writing on the prescription pad, and then hands me the prescription. And I was a little taken aback, and I said, can you tell me what this is? And he said, yes, it's a prescription for something you got to put all over your body, lie on the bed like you were being crucified. I thought that was effective, knew I was Jewish. And then you wait an hour and you take a shower and you do that twice and it'll go away. I said, doctor, I've been living with this thing for a year and a half. Can you tell me what it is? He said, well, yes, I can. It's blah, blah, blah. I said, well, how do you know that? And all those other people didn't do it. And he said, you were in the Caribbean, right? I said, yeah. He said, well, that's where I'm from. And you have blah, and this is the cure for it. Now go home and get crucified. And it worked. You got to keep looking. Sometimes we want not just what we want, but we want what we want to be easy. You want to take a pill that's going to make it go away, like that thing that the dermatologist gave me. Sometimes it can happen. Most often it's not going to happen. There are things you can do that are going to take a lot of time and a lot of energy when time and energy may not be an infinite supply. And the life space you're going to live in may be different from what you thought it was going to be. Stories about the itching and the shoes and the bathroom and sleeping on ice, all of those may become part of your reality. From the outside, it's like, I could never do that. Well, from the outside, it was like, I don't want a wheelchair. Well, from the inside, life in a wheelchair is just fine. Not such a big deal. I don't take the metro anymore. I do some things differently. I've changed some things around. My life is great. Of course, the students whose term papers I grade don't always agree, but I'm happy with it. Now, this leads me to probably the one point where my perspective may be a little bit different from my younger colleagues, some of whom I hope might want to grow up and become psychologists. I think they'd be great. I'll write them recommendation letters for graduate school, which is, do you or don't you want to live in the mainstream? There's a lot of great things about being with all the other kids, being in the mainstream. And sometimes some people don't want to be there. There were questions before about homeschooling. Homeschooling as opposed to 2 inadequate hours a week of home instruction can be a very viable option for some kids and some families. Glad to talk more about that. There are times when I don't want to go to a big crowded concert or be, quote, just like everyone else. Sometimes I want to live in my own space with other people with disabilities who are a disproportionate number of my friends. So you may want to be open to a range of options. One of my favorite cinematic moments is the bar scene in Star Wars. Anyone ever see that with all the different aliens, like milling around in the bar? I like that notion. And maybe that's who some of our allies are. So I'm not going to go on forever. What I want to talk a little bit about, what's different when a chronic illness happens to a child as opposed to when it happens to an adult. One of the most profound learnings in healthcare is the work of Herbert Benson, a physician at Harvard. Talks about the notion of remembered wellness and how it explains why 2 people can have exactly the same condition and a wildly different outcome. Some people with good outcomes are like the kids we got to hear this morning, who have some notion in their mind of how life can be and that one way or another they're probably going to get there, and that carries them through. And other people can't imagine or recall that, quote, remembered wellness, unquote, and the outcomes get real complicated. When adults have had a period of good health and then develop a chronic illness, they can work directly on remembered wellness, sometimes on their own, sometimes with the help of professionals. With a kid who is born with a congenital condition, remembered wellness may be there, good stretches, good moments, watching a sibling, something like that. Or it may be that you'll have that for your child, or you'll be pulling together the fragments. But the notion of how life can be, how it can be for stretches, how to get there, this is going to be really key. Life changes, and so no one else's life can be the model for your life or your household's life or your kid's life. Yeah, it's great to want to do things like other kids, and sometimes it's going to be the imagination. I can't play football, but I can ride a horse. I can't do this, I'm going to do that. You want to go with what works for your child and devote a lot of attention to that. Kids have an incredible developmental momentum. A lot of times when my colleagues who work with adults say, well, you know, how come you like working with kids? They can't just tell you what's going on, like some of our patients can. I say, yeah, that's true, but my patients get better and yours typically don't. No offense. Kids, that development carries kids through all kinds of stuff. And we heard from your kids, our kids, some of the things they like. Roller coasters, pizza, amusement parks. I would add comic books, probably video games, you know, stuff like that. One of my magic tricks is that in my office, I have these paperweights. They're blown glass paperweights. They're all made by teenagers. My brother lives near a deposit of a special kind of sand that people make blown glass with, and came to a point where nobody wanted to make blown glass anymore. They all wanted to write software programs, or I don't know what people want to do these days. And before the guys who owned the glass blowing place gave up, they called the local vocational school and said, by any chance you have a couple of people that want to learn how to blow glass? They found a couple of teenagers and they made my paperweights. When kids come into my office, they love my paperweights. And my paperweights cost a certain amount of money, and I like them, and I don't want them broken. But I tell my child patients, you can touch them if you're careful, and kids who are not respectful anywhere else are respectful with those paperweights. And when I have to go see a kid in a hospital, I always bring one of my paperweights with me. It's that kind of thing that gets a lot of people through. Bunch of points I don't want to make because I always write twice as much as I'm supposed to. What works in terms of parenting strategies? One, you have to know your own values. Now, another one of my magic tricks is that my desk is always a mess. And when kids and parents are having a fight over messy bedrooms and they come into my office for the first time, the kid looks at my desk, grins from ear to ear, and the parents look at their toes. This is an awkward moment for a psychologist. And I have this line that I often use in that situation. I ask the parent, well, you saw my desk, what's that like for you? And when the parent says in a calm and collected way, my kid is not going to have their desk that way, and they stare at me like, you might be fired. Let's going to see what you're going to do right now. I look at the kid and say, I'm not the one that's going to give you your allowance. They are. And that's how you get through. You respect the family's values. It's important to acknowledge and reward and celebrate the positive, the simple pleasures of the day. When your kid figures out about the silk sheets or the ice water bath or the oatmeal in the sock, let them know what a great thing they just did, because that positive feeling is going to get you through a lot. And another thing which you are free to quote to your children without paying me any kind of royalty fee whatsoever. Don't let kids get away with murder. So at appropriate moments, you can say to your child, well, I heard a very renowned professor of psychology at the weekend conference, and he said, not to let you get away with murder, so give it up. And that can sometimes get you through. Restore the balance. It's real useful to make space for letting your child tell you what they think, what they feel, what they want, and positively reinforce the value of them always being able to talk to you and tell you what's on their minds, even if it's the last thing that you want to hear. You want to keep that channel open. It's a great idea for parents to find someone you can trust, who you can talk to about specifics. I love the line, like, I tell the general version to most of the kids, and then I have these 3 people that I tell everything about Alagille to. You want that for yourself. You want someone where you can just let it all out. Might be a physician, and if so, it's more likely to be a family practitioner, someone like that, than the super specialist. Could be a nurse or a nurse practitioner, could be a member of the clergy, could be a great friend. Diseases happen in bodies, but they also happen in families. And you want to take into account the needs and the thoughts and the points of view of everyone in the family, even if any given moment in time you can't put it all together. Letting people have a voice makes a lot of sense. 2 more things and then I'm done. Plus they're getting together the lunch outside, so I know I gotta hurry. I want to mention, because I don't want it in a group like this to go without mentioning, that we're talking about positives, about good things, about tactics and strategies that can work, and they don't always work. And people go through awful times, and I would imagine that in a group of this size, perhaps some of you have lost children. Others of you may lose children way before their time. In that case, your child will become acquainted with my son, who I lost at a very young age. It happens, and it's awful, and there's that kind of time outside of time. And whatever gets you through that time, I want to acknowledge and I want to support. Every so often, less often these days than when my career started and we didn't have the great medications and treatments we have now, I lose a kid. And I live in a high-rise condominium, and I'm a pretty good neighbor. When I lose a kid, one of my patients, I play the drums, I play them loud, I play them at night. And I have the best soundproofing I can afford. And when I moved into the place where I live, I told all my neighbors what I do for a living, And if you hear the drums through the wall, I'm sorry, I'm not going to stop. If you want, I'll buy you earplugs. Won't happen all that often. You do what you need to do. And on the other side of that, what you've lived through with your child, it's going to guide all the rest of your life. A lot of other things I could do as a psychologist, I don't want to do any of them, because the privilege of being with kids and families struggling with some of the illnesses that we get our way through together, I wouldn't trade it for the world. So that's my best take on the propaganda that's useful that I can offer. And we have a few minutes before lunch. You'll tell me, please, when to be quiet so everyone can eat, but open to your questions. And if I can't see you when you raise your hand like this, go like that. And whoever's passing around the mic, that'd be great.
So do we have any questions? And then are you available afterwards if people would like to come up with and
I'm
speak with you privately?
available afterwards during lunch, absolutely.
Wonderful. So at that, I think everyone is starting to smell the food. So, but I want to thank Dr. Richard Ruth for coming and spending some time with us this morning. So we have lunch happening, and like we have before, the buffet set up. We'll come back in here, and we'll enjoy each other's company, and then Cindy will have some closing remarks in just a little bit.
Could have everybody's attention, please. We have just one more kind of semi-session, and then I have a few announcements to make, and we will wrap it up about 1:30. So one thing that we wanted to do was, we know that there's been a lot of information shared this weekend, and we thought that you may have some outstanding questions for our doctors, and we do have some of them still in the house. We have Henry Lynn and Alex Falsey and Chris Kerchowski. Okay. And then Lisa is still here, Lisa Bergson. So what I thought we could do is just kind of pass the mic around, and I actually have another one up here that we probably could use, because we're going to want one for the audience and one to for you guys. So why don't you guys come on over here? And maybe what we could do, yes, there you go. We'll get the big chairs. Well, yes, Alex wants to point out that she is not a doctor, but she can answer questions about genetics and those kind of things. And then I have this one that you guys could pass around that I think will work. So, I guess they've seen you all before, so did you guys have questions that you want to ask? And I will bring the microphone around. I'm also going to close the doors.
Are you guys ready? I just have a question regarding, our daughter does have Alagilles, but she's also being diagnosed with chronic fatigue, and she has vitiligo, and wondering if you guys have seen anything like that go along with Alagille, or is that totally something separate? We haven't really gotten a clear answer on that.
Oh, I guess you're passing the mic to me. Okay. All right, so I think the question is, in someone with Alagille syndrome, do we see some of these other symptoms, specifically with chronic fatigue or vitiligo? And I think vitiligo is a little bit less common. We don't see that as much. But I think from a chronic fatigue standpoint, there could be many factors that could be contributing to this. And so part of it is anyone with a chronic disease process. We know that children or adults with chronic disease, sometimes you can be a little bit more tired. So things that we look for would be, looking at the blood level, the hemoglobin level. If that's low for any reason, that could be a contributing factor. Sometimes people have lower thyroid levels associated with it, and so that's something else that could be contributing as well. And then also what we know is that, when your liver, depending on the severity of your liver disease, if your liver's sick or not feeling well, your body has to work harder to upkeep its functions, basically. And so for all those reasons, and really for almost any organ system, you can make the same case for, you can be a little bit more fatigued from that standpoint. Does that answer your question? Kind of.
Another question?
So I know they're doing a lot of work with like 3D printers and everything, and I was wondering if there's any technology where they're starting to 3D print livers or grow livers out of stem cells, and I was wondering if that is an option in the future.
Okay, so this is great. This is what I get for complaining about having nothing to talk about the liver yesterday. So, just to make sure I understood the question. The question is, what progress have we made from a liver standpoint, specifically of stem cells? Is that right? Yeah.
Because I know some people have bad hearts, and so you could get a heart or a kidney or any organ, really.
So there's a couple stages to that. First of all, can we grow an organ from cells? Number one, and then number two is, can we then put those cells or put that organ into someone? And so we certainly, in other disease processes, we can take cells and transplant them into people. So probably the best examples of these would be anyone with any sort of like cancers. They can take stem cells and actually transplant those in, and then they can kind of take over the formation of blood. Other examples would be like if you have any sort of problem making insulin, or like if your pancreas cells have issues, we can do pancreas cell transplants. But those are all on the cellular level, right? And so then you have cells that serve as the building block into becoming an organ, and we're not quite there yet, but that's where the research is at. So from a liver standpoint, we can actually take stem cells and we're able to start to create liver types of cells. But if you think about it, for any organ, whether it's the liver, the heart, the kidneys, to really make the organ, there's more than just one cell type in the organ. You have, in the liver, you have the liver cells, then you have bile duct cells, you have blood vessel cells, you have white blood cells in there. And so to be able, we don't have the technology yet to really be able to put everything together to say, let's make something that looks and works just like the liver just yet. But what we can do is that there's a lot of studies out there that have actually said, well, what if we take just the liver cells itself, because those are the cells that we want to function, and maybe not so much an Alagille syndrome because it might be more of a bile duct issue, but they can take the liver cells and they can actually put it on a synthetic scaffold. So basically, it's almost like you take almost like PVC piping, but shrink it down, and then you can kind of plaster liver cells onto it. And there's a lot of research out there saying, what type of scaffolds do we use to allow liver cells to grow, and then can we then take these cells and put them into patients? And so that research is ongoing, but we're hopeful that at some point in time we can figure out how to do it. The main limiting factors are, how do you find a material that your body is going to accept so that it doesn't reject it for any reason? And then also, how do you keep those cells alive and functioning well? Because it's one thing to say we can create a cell. It's another thing to say that the cell actually does what it's supposed to be doing.
Next.
Have you seen any connection with Alagille's and Gilbert's syndrome? I know my wife's sister has that. Just got recently diagnosed. I don't know if that.
Which syndrome?
Gilbert's.
Gilbert's? Oh. So I think Gilbert's syndrome is, or the French call it Gilbert syndrome, to make it sound a little bit more fancy. But it's an issue in which your body, so it's a bilirubin issue, and what happens is that your body doesn't conjugate the bilirubin as effectively, and so it doesn't get excreted as effectively. It's actually something that you see quite normally in about like 5% of the population. And so it could be a normal variant. And there might be, if you just look around the room, there might be a handful of us actually with Gilbert's syndrome, and without even knowing it, because what happens is your bilirubin is just slightly elevated. Maybe if a normal is less than 1, usually it's somewhere in the 2 to 3 to 4 range. And the times that when you see it is that when you get stressed out, you increase production of your bilirubin, and then you might look a little bit yellow. And so we haven't seen any specific correlation between saying if you have Alagille and Gilbert's syndrome, but again, so I think if there is someone who has it, it would be hard to say, because we think that in the underlying liver disease process, it's the reason why you have a high bilirubin is because of a kind of a drainage issue. You don't have bile ducts, so you're not draining. And so I think we would attribute the high bilirubin to that, and less so from like an enzyme deficiency in Gilbert syndrome. But it's something that could definitely be tested through blood tests.
What are the pros and cons of getting a living donor for a liver transplant as opposed to having a complete transplant? And are there age limits for a living donor? Those kinds of questions, really.
Oh, excellent. I might as well just wear the mic now. So the question is liver transplantation in Alagille syndrome. So I think in general, when you think about liver transplant, the outcomes that you look for are really dependent. It's dependent on a lot of factors, but the main things we look at is kind of surgical expertise as well as age and overall health of the patient going into the transplant. In general, if you are at a reputable center with good surgeons, the living donor versus kind of a deceased donor, so those are the two different options, the outcome should be fairly similar. So there really shouldn't be one advantage over another. Now, in Alagille syndrome, I think where you have to add a layer of complexity to it. So certainly if you, because we know with Alagille syndrome, you potentially have liver involvement, obviously if that's why you're having a liver transplant, as well as the blood vessels can be involved as well. And so for those reasons, we don't typically recommend having someone who is a known carrier of a JAG1 or a Notch2 mutation be that living donor. So assuming that you have a person with normal JAG1, normal Notch2, then I think living donor would totally be an option. So then when you're thinking about living donor, your options are limited in terms of the liver is kind of sits here on the right side. It's split up into right lobe, left lobe. And essentially, what would happen is for the living donor is you take a segment, or really half of the liver, or even a smaller segment than that, and use that as the piece of liver that you're donating, basically. And so on one hand, the downside to it is that you're doing an operation on the donor as well. So that's an extra risk to the donor. And then, there's recovery time for the donor as well. Usually we say about somewhere around the 2 to 3 month mark for the donor to really feel back to normal. And I think a lot of times they'll say, for the first 4 to 6 weeks, you're no heavy lifting or any sort of stress on the body. But from the patient standpoint, the living donors can sometimes be a little bit more technically challenging because you're basically taking branches of the blood vessels and branches of the bile ducts and connecting them together. So really, if you think about it, the blood vessels and bile ducts could be a little bit smaller, so that just adds a slight degree of technical challenge. And also, because you're essentially cutting the liver in half, or sectioning off the liver, sometimes that cut surface of the liver can ooze a little bit, and so that could also mean initially in the first couple of days you see a little bit more oozing from the liver, and it takes a little bit more time for the liver to recover that way. Otherwise, I think between living donor versus deceased donor, it really shouldn't be much of a difference. The things that we also think about would be, again, if you have the luxury to wait to say, I'm thinking about, we know that a liver transplant's coming down the pipeline. A lot of times it's nice to get on that deceased donor list, the wait list, basically. But at the same time, if you have some living donor options, it's nice to almost have a backup. Because clearly, anytime you do a liver transplant, there's always the risk of immediate rejection, or not so much rejection, but rather the liver not functioning or having any sort of clots to the blood vessels that might require you to then put in a new liver again. And so you never want to think about those options, or those scenarios. But again, having identified potential donors is nice to have a backup sometimes.
Healthy donor.
Yes. Sorry. So the question is age limit of donors. So I think most pediatric centers would say, the donors have to be over the age of 18 so that you can make a fully informed consent and the decision for yourself. The upper age limit is very center dependent. In Philadelphia, for example, the age, and Chicago, the age limit is about 50 years old. Of course, in Chicago, as our surgeon got a little bit older, he started pushing up the age limit a little bit because he thought, well, 50 can't be that old. And so, it's flexible is probably the best way to say it. So it's very institution dependent. But I'd say 50 is probably a general rule. to look for. And then also what they do is they'll look for overall health of the potential donor. We want to make sure that the potential donors aren't overweight or obese, because that makes the surgery a little bit more difficult as well. So we look for patients of a certain body mass index or lower. And then also what they would do is they would take x-rays, do x-ray imaging to really look at your internal anatomy to make sure that your blood vessels and bile ducts are actually compatible to be split so that you could be a donor.
I'm going to cheat and ask a question instead of passing the mic around for a minute. And my question is for Lisa. With vascular issues with Alagille syndrome, and especially stenotic vessels, one of the usual things is to go in and either balloon or try and put a stent in to the vessels. Are there other techniques, strategies for dealing with those stenosed vessels? I mean, things that come to mind are, what about, I don't know what it's called, but where you do oxygen saturation kind of therapy. You're in a machine or whatever, and they can flood it with oxygen, or grafts, vessel artery grafts or things like that to bridge that narrowing.
So I think what you're referring to, there's a patient population that has pulmonary hypertension, and their pulmonary hypertension is a reactive pulmonary hypertension. They don't actually have stenotic vessels or obstructions like I showed you yesterday. So if you give them certain medicines or oxygen therapy, it relaxes their vasculature such that their pulmonary artery pressure is lower. With the fixed obstructions of PPS, they don't respond to medical therapy as they are structural. So what I've described in terms of the tools that we have right now, low pressure balloons, high pressure balloons, cutting balloons, stents, if you have to, are the tools and techniques that we have available to us at the current time. The alternatives would include surgery, which is possible for the proximal pulmonary arteries, but the surgeons can't get out into the lungs, into those smaller blood vessels, so that's no longer an option.
With the mild pulmonary stenosis, when they're really very young and they find it to be very mild, I've heard, and in my experience as well, they've said it may never be an issue. Could there potentially be an issue, as I heard from another parent who went from mild to moderate before they were 10 years old? Can it go from a mild to a severe? And what's the likelihood of that if they don't have any other pulmonary issues other than, say, a murmur?
So a murmur is just a noise that we hear with our stethoscope, and it may represent really mild obstruction or more severe obstruction. So I mentioned yesterday the echocardiograms. So if the echocardiogram, they're pretty good at estimating RV pressure, either less than half systemic or greater than half systemic by the echocardiogram. And if it's less than half systemic, even if you have mild pulmonary stenosis, that's very well tolerated over a very, very long period of time, and you're really not at risk for the right heart problems. Surveillance echoes, if you do have mild PPS during the growing years, on say a yearly basis, should be adequate to not go from mild to severe. to catch that patient that went from mild to moderate progression. And if you progress past moderate or above half systemic, then the decisions become more complicated in terms of when to go to cardiac cath, because echo is an estimate of the RV pressure, but it's not, it's an estimate. So you need to know for sure. In terms of risk of cath, it's certainly from a procedural perspective and risk to the patient, it's better to go sooner rather than later. The more severe the disease, the riskier the procedure gets, and the more likely that there might be segments that have disappeared and closed off completely that you can't treat. Does that answer?
I had a question about kidneys. When our daughter was diagnosed, they I should have just said when she was diagnosed, they sent us in. Okay, we need to check the kidneys, and they did the sonogram of the kidneys. They said, oh, her kidneys are fine. They're not affected by Alagille. And we moved on. So she's 3 now, and we're starting to see those numbers, the creatinine and all of those start to go the wrong way. Is kidney affect something that can be developed? Should we be watching that more closely?
So that's a great question. The question is, does do the kidney manifestations, can they develop eventually or not? And I think if you, in the talk yesterday, I tried to delineate that there's different ways that the kidney can be affected, structural anomalies versus functional anomalies. And so I think when you first get the ultrasound initially when at diagnosis to say, let's look for, you're basically looking for any structural anomalies. And so those are pretty binary. You either have them or you don't, except for a few cases in which if you have like the lipid deposits. So some of those instances, it could develop over time. And so really what the ultrasound at diagnosis looks for is to say, do you have a small kidney? Do you have any sort of cystic structures? Do you have any sort of renal artery stenosis or reflux going on? Those are the things that we can look for initially. Some of those things, like I said, over time could develop. So the lipid deposits are one of them. Vascular, we don't really understand that much about in terms of the timing of development. So certainly renal artery stenosis could be something that might develop a little bit. But I think in your specific case, when you're talking about the creatinine and some of those other numbers going up, that's more from a functional standpoint. And the kidney function, I think, is something that we have to continuously monitor for. And so that's why usually we'll say, on an annual basis when you're getting your labs, we look at the creatinine, the BUN, and those other markers. And so that certainly could develop over time as well.
Since we had a diagnosis of Alagille, we were told that it's unpredictable. Some kids get better at 4, some kids get better at 11. Now that the children's study has been going on for a number of years, are you able to make any predictions based on the numbers that you see at the beginning? Is there any more visibility as to what the future holds?
So another great question, being about how can we predict about prognosis or the future. I think a lot of it still depends on which organ system is involved, and I can speak primarily on behalf from the liver standpoint. What we know is that the liver severity can definitely fluctuate, meaning that sometimes we have people with very severe disease who, as they get older, the disease gets more mild. And sometimes you have people with very mild disease, and as people get older, they get more severe. What we've seen through the children's study is that around age 5 years old, at least the liver phenotype tends to stabilize out, meaning that if you have more severe liver involvement after the age of 5, then likely you're going to have more severe liver involvement. And if you have less severe involvement, then that's going to typically be the case from a liver standpoint. Outside of that, I think the biggest challenge that we're facing with the children's study is that we have all this data that we're collecting longitudinally, long term, to say, what are we, are there any patterns that are emerging? And so what we've done on some levels is to say, well, can we see if certain organ system involvements are associated with other organ system involvements? So meaning that, like, if you have severe liver disease, does this put you more at risk for having kidney involvement or eye involvement? And actually, our lab just finished up kind of an analysis of over 400 people with Alagille, and we didn't really find any great patterns to that, unfortunately. So the short answer to your question is that studies are still ongoing. We haven't really found much, but we do know, at least from a liver standpoint, that 5 years seems to be a good hallmark to give us a sense of the severity of liver disease.
Any more questions? Oh, we're at a stopping point, maybe.
So I just want to say really quickly, we have had a good amount of people give skin samples, so thank you very much for that. We still are accepting any willing participants. Dr. Lin has had a lot of practice now, and he is excellent at doing it. And again, anyone who is not enrolled in Dr. Spinner's study, we would also love a blood sample. And if you have any other scientific questions, I'd love to answer them.
And just to reiterate what Dr. Lin said, and just to echo what Chris said, we are looking to try and answer a question of liver severity and case severity. And so we are comparing individuals with different mutations to see if there's anything else that we can use that would help us predict or would help us with the prognosis. So any samples you can give, we can then characterize, and the better we understand the different genetic mutations, the better we can look at prognosis and start to make those correlations to say, if you have this, we should be looking for that. And so your participation really helps us in terms of helping you back. So please, please, please don't hesitate to come to us. That's our sales pitch.
All right, well, thank you very much for answering those questions. And like I said before, I know that there's been a lot of information shared this weekend. And so if you do have any other questions once you get away from here and you're able to look through the information, you can always email the Alliance at alagille@alagille.org. And we'd be happy to pass on your questions, to talk to our medical advisory board and see if we can get some answers for you. So you know what? You guys are free to leave your seats. And while I have everybody's attention up here, I think it's 8. Little announcements, and then we're going to let you get out of here and head home. Yes? I'm going to get to that. That's one of my eight points up here. So number 1, one more plug for the Game and Picnic on September 27th at 1:30 in the afternoon. Their email is lgehman, GEHMAN, @excite.com. And they would be happy to answer any questions you have about that. 2 is the evaluation forms. If you haven't done your evaluation forms, please do those. And there's a box out on the registration table it says registration forms. If you'll put those in there, that helps us a lot when we are planning our future events. Number 3 is about our patient registry, the Alliance Patient Registry. You can go on our website, and there's a link to that. I'd encourage everyone to sign on to that. We haven't sent out much in the way of newsletters or announcements via the registry, but we will be doing more of that in the future. So we'd like to get everyone enrolled. And if you do need assistance with that, let us know. It doesn't take very much time, and we'd be happy to help with that. Scholarship checks. Travel scholarship checks. If you have not gotten it yet, Patty back there has any remaining scholarship checks, and please see her, and she will give those to you. I don't know if there's very much in the way of free toys and things out here on the table. We did have some leftover things. Okay, but please feel free to pick those up as you head out the door. Oh, no. Yes, the thumb drives. Yeah. We have very cute thumb drives for everyone. There's one. Darren's holding it up there. It's a little yellow guy that has our logo on it. And Eric, our IT person, has been working very hard to load all of the PowerPoint presentations from the weekend. Those are on there for you to review at your leisure, along with the program, and I'm not sure what else. But he will be at the registration table out here as you leave this part of the hotel, and he will hand you one as you go out the door. Let's see. Oh, one of the big announcements is that the Alliance has always been a volunteer organization. Our board is volunteer. As president, I am a volunteer. And we are totally thrilled to announce that we are hiring a staff person. For the first, our first ever. Her name is Wendy Sparks, and she will be starting on July 15th as our Associate Executive Director. And it's going to be a remote position for her, although she is located in Oregon, just like the Alliance is. And so we're hoping that with adding her, it's not only a big step for our organization, but we're hoping that it translates into enhanced service for all our families, and just leads to more growth in our organization and our ability to continue to serve all of you. So I think if no one has any questions, I can just thank you all for coming. It's been a really wonderful weekend, and we wish you safe travels. And please don't hesitate to get in touch with us at any time, and we are happy to help in any way that we can. So thanks a lot.